So this is a seminar to which you're very warmly welcome. My name's Joanna Schellenberg, if you don't know me, and I'm an epidemiologist working here in the Faculty of Infectious and Tropical Diseases, and I'm a director, a theme lead for the March birth theme, and this is a March seminar. And I am really pleased to be able to welcome our two speakers today, who are doing a double act. Wuleta Mariam and Ali Karim, both from Ethiopia, and they're going to be talking about
they're looking at you from Ethiopia.
Yeah, we'll get to that. Both working in Ethiopia. Is that okay?
Yeah. Even the first one was okay.
Okay. Both working in Ethiopia. So talking to us about engaging communities for improving reproductive, maternal, newborn and child health in rural Ethiopia. So I first met Ali and Wuleta about 5 years ago, and I can say a few words to introduce both of them, and then I'm going to ask them to speak. They told me that they have around about half an hour to present. There should be time for a bit of discussion, a few questions. I do want to wrap the whole thing up by 10 to 2, so that people who have classes or whatever to go to for 2 o'clock, you don't feel that you have to walk out in the middle. So that's what we're aiming to do. Let's see if we manage. So I'm going to start with Ali. So Dr. Ali Karim, who has lots of initials after his name, MBBS, MS and PhD. So Ali is the Senior M&E and Research Advisor of the Last 10 Kilometres project, which is a project of John Snow Inc., JSI. Ali has been in his current position, I think, for over 13 years. Before he worked with JSI, he worked at Tulane University, in ICDDRB and at BRAC. And his interests are in natural experiments, effectiveness evaluations of large-scale programs, survey sampling methods, program performance measurement, HMIS, and effective communication of research and program results. So lots of things that are very relevant to a lot of stuff that we do here. And Wuleta has more than 20 years of experience in strategic leadership for public health programs globally. So Wuleta is currently project director for the Last 10 Kilometres project in Ethiopia, which is funded not only by the Gates Foundation, but also by UNICEF, USAID. And it's a project of JSI, John Snow Inc. So prior to her current position, Wuleta was deputy director of Engender Health's program in New York. And before that, she established a gender health presence in Ethiopia, as well as a program in Sudan, and was country director for both countries. So Wuleta has a master's degree in public health and public policy from the University of Michigan. And I know she's currently involved in a doctoral program in University of Illinois in Chicago. So welcome both of you.
Thank you. Alrighty, thank you for the introduction and for the invite, Joanna. So Ali and I will be sharing the presentation today. So I'll start up by providing some sort of a context about the Ethiopia health systems and about the Last 10 Kilometres project, and then Ali will follow up with, so what the results that we've been able to achieve over the last couple of years working in Ethiopia. Okay. So even though Ethiopia has had tremendous progress in terms of decreasing maternal, newborn, and child mortality, the mortality rate still remains extremely high, as you can see, at 4.2, 28, and 68 deaths per 1,000 lives for MMR, NMR, and under 5 mortality, respectively. Ethiopia is committed towards achieving the maternal mortality, newborn mortality, under 5 mortality reduction targets of the SDGs. And Ethiopia usually has a 5-year plan, and the current plan that we're working under is called the Health Sector Transformation Plan, and it aligns with the target that the SDGs has put forward in terms of decreasing those 3 mortalities that I mentioned. So by 2020, the target is to reduce all the mortalities by 50% or more, to 10 and 38 per 1,000 deaths for MMR, NMR, and child mortality. So one of the ways to try and achieve this target is enhancing community empowerment, engagement and participation is one of the key strategies that the government is working on, and MNCH's program actually fits within that community engagement and empowerment and participation process. So I'm just going to go quickly through the health systems because I think it's important to understand the context. So the Ethiopia healthcare system is three-tiered system. So at the base of the health system is the primary level healthcare, which includes the primary hospital, health centers, both in the rural and the urban area, and health posts, which are at the community or village level. The second tier is the general hospital, usually serving between 1 to 1.5 million people, and the tertiary care at the tertiary level provides services to 3.5 to 5 million people. So we're going to do a little deep dive in terms of trying to understand the primary level healthcare. So the primary level healthcare, as I said, encompasses the primary hospital, the health center, and 5 health posts under each health center. So the primary hospital serves between 100 to 200,000 people, and it's usually in a district. So the district has between 100 to 200,000 people living in it. And a primary level hospital has about 25 to 50 beds and provides several services, including comprehensive emergency and obstetric newborn care services. The primary hospital is a referral point for health centers and is also a point where health center staff get their training and supports and mentoring and coaching types of activities from the primary hospital. Under the primary hospital is the health center, and I'll go deep dive into the health center. So under each primary hospital, there's usually about 5 health centers under their purview, and each health center, as I said earlier, has 5 health posts that provide services to the community. So now we're going down the level since we want to talk about the community health program. So the primary healthcare unit, as I stated, has the health center and 5 health posts under the health centers. And the health center serves between 15,000 to 25,000 people, and on average has about 20 staff. The health centers usually don't have a medical doctor there. Usually health officers, nurses, midwives, lab technicians, pharmacists, but no medical doctor. And usually has about 5 beds for emergency and limited inpatient care. Most activities at the health center is preventive and curative. And at this level, health centers provide basic emergency obstetric care. So as I said, the hospital is the one that provides the comprehensive, and here it's the basic. The health center is the referral point for the health post, and again, it provides the technical support and training for health extension workers. And the health extension workers are posted at the health post. So currently, we estimate about 34,000 health extension workers placed in about 50,000 health posts nationwide in the rural areas. So it's a wide, massive community health program nationally. So as I said, the health post, which is the base of the health system, serves between 3,000 to 5,000 people, and 2 health extension workers who are all females and are actually 10th grade graduates who get 1 year in-service training and a whole lot of post-service training throughout their career, are placed at the health post, and they're supposed to provide services in their health posts, in the static health post, as well as through outreach and going to house-to-house visits. So the health extension workers are supposed to provide 16 packages of health services, mainly promotive, preventive, and basic curative services. Some of the activities, as noted there, includes providing implants as a family planning option, integrated case management of childhood illnesses. They do treat newborns for sepsis. So they do both promotive, preventive, and limited curative services. And the health extension worker are government salaried workers. So this is basically part of the health system. So working together with the health extension workers are what we call Health Development Army, Women Development Army. So you hear both terms used. But the Health Development Army is pretty much all women. They're volunteers who actually work with the health extension workers. Basically, they're their arms and legs out to the community where they provide promotive services, health education to households. So it's a little bit a complicated kind of a structure, I guess. So there is a health development team. So the team lead has about 25 to 30 households under her purview. And then the 25 households are divided into 5 different networks. So there's what we call the 1 to 5 networks. So 5 1 to 5 networks together make a health development team. So the idea is that the 1 to 5 network, it's basically neighbors who live very close to each other, who have different kind of social engagements, drinking coffee, and those types of things, where they sit together and talk about their health. And 1 to 25 health development team leader basically pulls information from all these different 1 to 5 network and provides that information to the health extension workers so that they can provide targeted services. So the HDAs, in addition to providing the health education, also are trained to identify danger signs of especially pregnant women and sick children. So this is a typical terrain of Ethiopia, so you can imagine why the government has decided to do community-related health provision. Houses are pretty scattered, so providing health services is very difficult if you're just statically in one place. So you really have to go out and reach out people who are living in different areas. So health extension workers will tell you that they might walk 2 to 3 hours to get to a household to provide a service. So we always say if it was men, then services would not have been provided, but they've managed for now almost 10 years. This program started in 2003. So over 10 years of providing services through the different programs that I indicated. So now on to the last 10 kilometers project. So as Joanna said, the project is primarily funded by the Bill and Melinda Gates Foundation, but we also receive grants from USAID and UNICEF. And primarily the space that we work in is at the primary healthcare unit, where we try to improve the interaction between households, the Health Development Army, which is the community, and the Health Extension Program and the primary healthcare unit for better outcomes in reproductive, maternal, newborn, and child health services. We work very closely with the government and we're working on contributing towards the HSTP, or the health sector transformation plans, goals, and objectives. So through our grant, we cover about 240 districts, which is about little above 30% of the population. So you can see on the map areas that we currently cover. So for this presentation, we're not going to talk about all the different components of the last 10 kilometers project. So we'll focus primarily on the Bill and Melinda Gates Foundation funded program that we implemented between 2012 to 2015, which is basically focused in 115 districts, where we've what we call our LTK platform, community-based data for decision making, which is basically a tool that helps the health extension worker work with their HDA to extend her reach towards the community. So, and that also has different components, which I'll go through later in terms of, well, I'll go through it later rather than repeating myself. So that we've been implementing in 115 districts, and then we also have specific community approaches that we've implemented in limited number of geographic areas to test basically the value add of these different community approaches. So one of it is called the Participatory Community Quality Improvement, PCQI, and the other one is Early Care Seeking and Referral Solutions, which we also implemented in 18 or rather 16 districts. Okay. So the community-based data for decision making approach primarily facilitates the use of data at lower level to improve performance. So as I noted earlier, the HDA team lead has about 25 to 30 households, and with the help of the 1 to 5 network, she maintains a surveillance to ensure targeted RMNCH services are provided. So in addition to using the data to ensure that these targeted services are provided, the data is also used to monitor coverage and for her to work with her local administration to identify gaps and pool resources that are necessary to make sure that the gaps are filled. So just to go through this schematic very quickly. So the HDAs, I wonder if is there a pointer?
The button, top button.
Yeah.
It's not working.
Okay, never mind. I'll just do the numbers. It's not working for me. So the first thing that happens is that the HDAs have a map, and you'll see a picture of the map. That's the women that have 25 households under their purview, and they map the different health needs that their catchment area population needs. So if there's a pregnant woman, or if there's a newborn baby, or if there's a family planner, they basically identify the needs of the households, and they use that map to interact with the health extension worker to basically let her know that these are the services that are needed in these households. The reason that's important is that the health extension worker, so as I said, there are 2 within a health post, so each has about 500 households that she's taking care of, and you can't have all the 500 households be treated equally. So places where there are pregnant women, newborn babies, kids to be immunized should be prioritized. And so this CBDDM helps in doing the surveillance and then passing the information from the Health Development Army to the health extension worker. So the health extension worker meets with her Health Development Army every 2 weeks and gets all the information from the Health Development Army. And she knows basically what households are needed to be focused on. And HEW meets with the HDA in groups and analyzes their data, and they have a checklist that I'll show you to measure progress and identify gaps and plans. Then every month the health extension worker uses that information, collates the information, and provides through their monthly meeting at the local administration level. They look at what their progress is, what the gaps are, and if there's any need to pull resources from the health system. So they use that for decision making. So this is the simple map that the Health Development Army uses. So you can see that they're like huts with different signs. So I can't do this. But let me just do this. So this would be a house with a pregnant woman. So yeah. But in any case, there are different kinds of stickers that are put on the household, basically identifying if there's a pregnant woman, if there's a newborn, if there's a kid that needs to be immunized. The idea of it is to have continuity of care provided. So once a pregnant woman is identified, the HDA identifies a pregnant woman in her catchment area. She ensures that she gets her prenatal services, is counseled. They have a family conversation, which the health extension worker brings together family members who are influentials within the family, because at the end of the day, most of our Society, though, might be different these days. The decision maker is not just a woman, but it's also mother-in-laws, husbands, neighbors, influencers. So they come together to basically talk about birth preparedness and emergency readiness, and then deliver at the health facility, and then move forward to having postnatal care services, newborn care services, immunization throughout the continuum of care. So this is basically the way that we monitor. The Health Development Army monitors the different actions from each household. Once she delivers, or once she identifies a pregnant woman, she follows through the different elements. I don't know, from the picture if you can see, that's ANC, family conversation, discussion about birth preparedness and emergency preparedness, rather, delivery at the health facility. And then once a baby is born, we identify if the baby is alive or not, and then, or she identifies if the baby is alive or not, and then moves forward with immediate breastfeeding through the newborn care. Family planning is also part of the counseling that happens during that time, and onwards to immunization, ensuring that all the immunizations are done, and then complementary feeding and growth monitoring over, so basically this takes you over the 1,000 day cycle. So this is just a picture of the health extension worker gathering information from her Health Development Army, and health extension worker also using Family Health Guide, which is that book that they're looking at in terms of using to educate families about different health practices. So there's a newborn there, so most probably they're talking about newborn health here. And this is what I talked about earlier, the family conversation. So it's families sitting together and talking about, once the pregnancy is identified through the ANC process, families sit together and using a very pictorial guide. They talk about birth preparedness and preparedness and emergency readiness. So that's a typical family conversation. So the next, so as I said, so the 20-based data for decision making has been implemented in 115 waradas, and the two other community approaches that I'll talk about have been only implemented in selected number of districts to look at the added value. So this is the participatory community quality improvement, which is PCQI. And it basically looks at, so basically the idea is engaging communities with health workers to identify barriers and bottlenecks to delivering health services. So the first step is exploring quality issues, where households and communities and families talk about barriers from their own perspective, and health workers talk about barriers to delivering services from their own perspective. So it's done separately. The primary healthcare unit, which is the health center, facilitates these conversations. And then the facilities and the communities come together under step number 2, which is bridging the gap. So they have a discussion in terms of coming up with the common issues, bottlenecks that they together would want to address. So they identify the common bottlenecks and come up with an action plan to basically implement it. So there's the implementation that happens. Evaluation and revised plan pretty much happens 3 months to 6 months is the cycle time for the PCQI activities. So this is a typical discussion amongst the communities as they're exploring their issues that they want to deal with. So examples of some of the community actions that have taken place are facilitating transport of vaccines and other supplies. So if the issue is that vaccines are not available at the health facility level, at the health post level, or through outreach, then they pull the health system in to make sure that those vaccines are available during the times that they're supposed to be provided. And it could be improving the health infrastructure at the health post level, availing water and electricity, which are pretty essential, but are not there in most of our health posts. Transporting laboring mothers. Now there's ambulance actually at the warada or at the district level, but to get to a road, there might be need for neighborhood people to carry women at least to a place where the ambulance can come. So it's basically enabling that to happen and building accommodations for health extension workers. So usually what happens is that the government did place those women to work at the community at the health post level, but they didn't provide them with housing. There are counterparts in the agriculture development agents who have been provided housing, they're men. So the women were supposed to be fending for themselves. So through the PCQI process, we've been able to build support, or we, meaning the community, we don't inject any resources into this. It's community resources that are implementing this. So build accommodations for health extension workers to provide services. So that's the 14 districts that I mentioned earlier, and in the other 16 districts, what we worked on is early care seeking and referral solutions. So this is basically to show that community engagement is also key in terms of identifying, what are the available assets to build on to improve the referral solutions. So the first step in trying to identify the action steps is mapping of resources that brings together the communities and health facilities together to see, what are the available resources to support referral actions, and then they again have a participatory design process where health facilities, meaning health centers, hospitals, and communities, including health development, army, health extension workers, sit together and try and come up with an innovative way of supporting the referral work. And then there's an active management of referral, which is basically the action points that comes out of the participatory design, is implemented, monitored, and evaluated. And Ali will go through the results of the work that we've been doing from here on.
So as Ulata mentioned, we cover 150 districts, which is about 3,000 health posts. And to monitor our community-based data for decision making, they go and look at work with the health extension workers, HEWs, and see what's going on. And we're measuring this spread. Basically started from 2012 and ended up in 2013, late 2013, and we are monitoring the spread of CVDM over time. And these were the 4 indicators that we are measuring. One was percentage of HDAs in the Kavale mapped their households. The other is the HDAs who reported CVDM data to the HEWs, or the HEW collected data from the HDAs. And the third indicator we used was percentage of health posts maintain CVDM data records. So if we found that they have good records in their health post, maybe they're using it and then actually using the data. So over time, these are the first 3 columns are from the supportive supervision that we were doing, and we see that over time it was increasing. Data use did not increase a lot. This was a survey we did. This is a random sample of 316 Kavales, where the numbers look basically similar to what we found during the supportive supervisory visits. So using these 4 indicators, a scale was developed to measure the CBDM implementation strength, which is 0 to 10, which 6.3 basically means that 63% of the full strength of CBDM was implemented in the urgent area during the time. So one of the vital thing about CBDM was to make sure to early identification of pregnancy and to make sure newborn care, maternal care, and all that. So from the HMIs, we got a number of deliveries taking place in the Kavale and divided that by expected number of deliveries based on the population size. This was on the x-axis, and the CBDM score. So Kavales with higher CBDM score had a better pregnancy identification rate. I'm not going to go through the methods but just to show you that we found our strategy was effective in improving CPR, institutional delivery, some of the newborn care indicators, and so this is the effect of the platform that we found. And with PCQI, we also compared areas with platform areas with PCQI, platform areas without PCQI. I just wanted to add that with USAID funded, we also strengthened the health centers to provide BMOC. And so PCQI had BMOC plus PCQI, and the platform area just had the platform plus health centers strengthened. So you can see that we saw some better effects of PCQI on some of these indicators. For the referral solutions, we did not have impact evaluation design because it was started later in the project and we could not design it. But from program monitoring data, we see that there has been a lot of improvement in terms of adherence to referral protocols from the community or the health post to the health center. So we looked at whether the referral slips were used, whether ambulance were used, if there was an advance call to the health center to make sure there is someone ready to receive the mother, then whether the mother was escorted, and whether the health center sends feedback to the health extension workers, so what happened to the pregnant woman. So these, you can see the trend was increasing. So the major policy impact that we made with CBDM is that it got picked up by the government national strategy, and it is part of the national strategy now. So what were the issues that that made this happen? Basically, our community engagement strategy, pregnancy care, this was aligned with the government strategy. HDA, the government deployed HDA to support the health extension workers, but there was not a fixed strategy how they're going to be working. And so the L10K CBDM looked very attractive, doable, and it was very aligned with the HEW health force. And policymakers, when they saw this, they very quickly adopted it. And we also, L10K working with the government has a lot of credibility. They trust us. And also there was a lot of donor support to make this expansion happen. With PCQI, one of the basic lessons that we learned was that community participation is important and should be part of the health system. And it's not just strengthening health centers is good enough. You need some sort of a linkage between the health center and the community. While the CBDM is working really at the community level, health post, the PCQI basically linked the health center, health post, and the community together, and that seems to be made a lot of difference. And communities want to take part in the quality, the improvement of the health system. So the major lessons from the referral solution was that you saw the three-step process, where data, with using the data, community sit down, identifies the priorities, and then comes up with a solution. So initially we thought that we'll just take the solution and spread it everywhere. But then through our implementation research, we found out that the whole process of identifying the problem, taking ownership of the problem, and coming up with the solution was very important in implementing those solutions. So the whole idea was that we learned that this is a community has to be constantly part of the whole cycle of improvement. So you see that our PCQI was isolatedly implemented in 14 districts. Referral solution was in different 14 districts, and the CBDM was in everywhere. So our new strategy going forward right now is like from last October, we have just mingled all these three strategies together, and where we bring the learnings from the referral solution, where we work with the hospital and the health center and the community with the QI cycle, and at the same time there's another QI cycle going on at the cabinet level, which is the health post and the community members. So this is our new strategy going forward for community engagement. Thank you.
Thank you.
Thank you very much to both of you. Any questions, comments, thoughts, reflections? While you're thinking, I'm going to start by asking a question. Ali, you mentioned this concept, which we have talked about before, of implementation strength, and you've got a score of implementation strength that goes from 0 to 100% or 0 to 10, whatever.
Yeah.
And you've got that what looks like a clear sort of increase in the dose of the implementation. So my question is, I know what 0 is. 0 is 0. But how do you or we or anybody conceptualise what is 100%? What is perfect implementation? What's sufficient implementation? So just any reflections on that?
So basically, when we can see that you're using 4 indicators. We have to go back, look at those indicators, and see actually what is going on. And you'll see that HDA mapping was done 100%, and then data is going on around 70% and so forth. But the data used by the Kabyle command post, where the administration, Kabyle administration, the community administration actually looks at the data, and the HEW interacts with the administration, and uses the data for overcoming problems that she's facing, is kind of low. It's like 40%. So when you say that the implementation strength is 10 or 100%, you would mean that data use is also there.
Right.
So basically, the data capturing mechanism is more or less universal, but the data processing is more than half, but the utilization is low. So when we talk about full strength, we talk about that all the 4 components are.
Yeah. And just to sort of play devil's advocate, it could be that without that data use, you haven't even started to get the effect. Do you know what I mean? Or it could be that you've got a perfect scale already, and do you know what I mean? It's like it could be data use is essential in order to come up with an impact on outcomes.
Yeah.
But we don't know. And
Right. Yeah.
so it's just sort of, I don't have any solutions there. It's just drawing attention to that issue of
But have we
what's
looked at
maximum implementation?
Yeah, so have we looked at outcome based on the different levels, implementation strength levels? I think we have.
Yeah. It's hard to get. These are like so combined with each other, intertwined with each other. It's hard to have an independent, saying an independent influence of.
Yeah, and by nature they're not independent. That's the whole point.
Yeah.
So they work together. So there's some synergies.
Yeah.
And
Anyway,
the lower
yes.
the score, the lower the increase in outcomes, right?
Yeah.
That's what we found out in this meeting, at least.
Yeah, yeah. So Christina was nodding. Is that? Did you have a question? And Tanya, and I'm looking for more. Yeah. So sorry, I don't know your name, but you're first.
Yeah.
Go for it.
I'm very interested in the process of refining your interventions. So with the CBDDM and the PCQI, did you, at the end of your 3 years, was it the same as the beginning? And how did you go about refining them? If you did?
Yeah. No, nothing was the same as
Yeah.
the beginning. I mean, there's always a process of refinement. With CBDDM, where we started and where we ended is pretty different, and with PCQI, where we started and where we ended and where we're going is completely different. So in the middle, we've done different process evaluations to look at, what's working, what's not working, what do we need to tinker. So there's always continuous learning. So yeah, we've never ended up.
What were the big differences between the beginning and the end?
So for PCQI, for example, when we first started, the participatory committee quality improvement, I always have the hard time saying the participatory part. So the facilitation actually was in the beginning when we first started, we wanted to make it independent from the health sector so that people feel free to talk about it. So the people who facilitated the discussions were school teachers, school directors, basically who did not have the depth health knowledge. So that didn't work out. So we had to move back to the health center staff to help in the facilitation process. So that's a complete different switch. As an example.
Yeah, well, my question was picking up on this data use issue because there's a huge amount of interest in it, and I think a lot of donor interest in funding it. And I'd be interested to hear what LTK could share about what you've learned about the levels at which you found data use more successful, one, and two, whether you tried any strategies to enhance data literacy. What did you do to try to address the data use element?
So, I mean, we did before starting our new project in October, we did a rapid assessment of what's going on, and data use seemed to be happening in areas where the Warada administration, it's not the Warada health system, it's the Warada administration was aware of this whole program. And the Kabyle administration was also very much aware of the program.
So
and
leadership.
The leadership, yeah, the commitment and leadership was a big
Not of the
issue.
health system, but beyond.
Beyond that,
Yeah,
the
beyond
administration of the of those geographical units, and those were the, I mean, major drivers. I mean, if they are involved with it, the data use was happening because they were asking for data. Yeah. So if it was about their literacy about our program, and they quickly saw that, you know, how beneficial it was to use the HDAs to actually do this, because they just know that, you know, HDAs are being trained, and what are they doing? You know, they're fuzzy about it.
Right.
So when they see this program, they kind of visualize, oh, this is what the HDA is supposed to do. And so, you know, the HDA is responsibility of the administration also. It's not just the health system.
Right.
So that's why it's a top-down system in Ethiopia. So the government, so that's very high commitment. Is, you know, you see a lot of things with.
That's if you're asked about it by the Warada administration, by the district administration, you definitely are going to do it. So working with the administration, I think, is the most important, as working with the people who are implementing it.
Yeah.
So spending time with the administration is.
And so the barriers to data use weren't around the capacity of people lower down the system to use the data, it was sort of just around having that attention played.
Yeah, because it was, because, you know, the health management information system is based, the coverage data from health management information system is based on projected denominators. Yeah. So the HWs are given, this is your population, so you must have so many mothers and so forth. You know, Mariam visited us in Tigray once, and this HW was telling her this, that, you know, before we did not know where these numbers are coming from. Right. Now with this CBDM, we can visualize exactly where these numbers are located. And this is coming from, you know, HW. So this is basically, so the use of data, whoever, you know, if the HW was committed or to do better, so it was a different angle to the HMIs that CBDM was providing. So it was promoting data use at the individual level. This is not aggregate level. Yeah. So at the aggregate level, we have given them some tools to educate the Kabyle command post how to you know, interpret and use data. But I think we still have more room to do better, and, you know, so that they are more engaged. The more they understand the data use, the better.
Collecting data, though, in Ethiopia, as you've seen on the walls of health posts, it's pretty common. Using it is the problem. Yeah. So their data visualization, I mean, there's data from like 4 years onwards until today in terms of, you know, what are the services provided. So it's there, it's collected. The issue again is, what does that mean?
It's kind of who's it for, really?
Yeah.
Is it just for show, or is it actually to make some decisions later?
Yeah, so it depends, it totally depends on the health extension worker. A motivated health extension worker would know exactly why she's collecting that data, what she's going to be doing with that data, and make decisions.
So we just have, if it's a quick question.
Yeah, it's a fairly quick question following on from the previous conversation about the implementation strength. And I was just wondering if you could speak to the metrics you use for implementation strength and sort of how and why you selected those indicators and substance.
Basically, those were the 4 major activities under CBDDM. So we just,
So you mapped it out.
yeah.
But you weren't, I guess, looking at sort of the readiness for implementation of the health posts themselves or the facilities.
No, readiness, I mean, it's assumed that they're ready because the HDAs are part of the government system, and so it was a given fact that HDAs will be there. But yeah, a lot of places, the low score is also associated with where the HDA selection was not proper, or the whole system did not, whole administration did not select the right person, so you don't see the coverage high in that case.
Okay, it is 10 to 2, so I think we're up to this. Can we just thank Ali and Willetta again for coming a long way and giving us this seminar? Thank you. Thank you.